Hello, welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pennell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. Today, I'd like to talk about a complex issue that affects all oncologists, and that's the use of chemotherapy near the end of life. While many people, hopefully most of us, would agree that giving chemotherapy in the last days and weeks of a patient's life is not an ideal practice, unfortunately, it's still quite commonly done. And while many publications and studies focus on this as an issue of poor quality end-of-life care and propose incentives to limit aggressive care at the end of life, I don't think enough attention is being paid to the reasons behind why oncologists are still doing this. Joining me today to talk about this topic on behalf of her co-authors is Dr. Maria Silveira, Associate Professor of Medicine and Associate Director of Palliative Care Research in the Division of Geriatric and Palliative Medicine at the University of Michigan. And she's also a clinician researcher in the Ann Arbor Veterans Administration Geriatric Research Education Clinical Center, here to discuss her paper titled The Paradox of Prescribing Late Chemotherapy, Oncologists Explain. Dr. Silveira, thank you for joining me.
Thank you for your interest.
So, first of all, can you just give me a little background? How big of an issue is the use of chemotherapy near the end of life in patients, and why do we care so much about this issue?
Well, I think over time we've grown increasingly interested in what happens to folks at the end of life, initially because of the quality of death people are experiencing and as well as the expenses that we have as a country in that area. One of the things that we've realized is that more care doesn't mean better quality of life. In fact, it's the other way around. Looking into these topics in a little more detail, one of the areas that's come out as an area of concern because of its prevalence is this notion of giving chemotherapy when people have less than 4 weeks to live for new chemotherapy and less than 2 weeks to live for repeated chemotherapy. And a fair number of people die having received chemotherapy within the last 2 weeks of life. And so I think as a country, it's something that people are interested in from the perspective of how people die and how much we spend at the end of life. But of course, many of us as clinicians are interested because we see people suffer, and we always wonder about whether or not we're contributing to that.
So when you designed this study, what was your thoughts about the study? How did the idea come about?
Well, it came from a couple of places. One is I always try and use my clinical experience to inspire my research. And as a palliative care physician, one of the things I frequently encounter is trying to co-manage patients who have cancer with their oncologists when the patients are severely ill and dying in the hospital. And the negotiation of what to do about their chemotherapy is basically, at times, depending on the oncologist, a very difficult one. And as palliative care providers, we really try to understand everyone's point of view in the room, including the oncologists. And so for a very long time, at least clinically, it's something that I've had to think a lot about, navigating this space.
What were the major themes that arose out of the paper?
Well, the first one is something that I think is not a surprise to anyone, that clinical factors take priority in terms of the issues that weigh in heavily into whether or not chemotherapy is offered to a patient. So factors like performance status, stage, comorbidities, evidence. But then there is a space where those factors aren't helpful in terms of guiding an oncologist. And then that's when oncologists are vulnerable to the second factor, which is patient and family preference. And by and large, they view this problem of administering late chemotherapy as a patient-driven decision that they supported. And then the third thing that we saw was a tremendous amount of stress among the oncologists, and stress that came up in the course of talking about late chemotherapy, leading us to believe that the stresses do influence how much emotional reserve the oncologist may have in terms of dealing with these issues. And oncologists feel they experience a lot of emotionally draining communication, and that in turn makes them more prone to prescribe chemotherapy when patients and families insist on it.
You know, if you think about this idea, all three of these make perfect sense. The second one, I think, is in a way sort of a no-brainer. The patients don't want to give up, and they are appealing to their oncologist for more treatment. But do you think in a way that it's really the responsibility of the oncologist to try to guide them away from that rather than kind of give in to their wishes when they know that it's not going to be helping?
Well, I think the oncologist is really in a very difficult position, and I feel for them. So I'll begin by saying that, because I feel it's easy to criticize oncologists, but if you live a day in their shoes, you'd understand why some of these things happen. I believe it is our responsibility, providers in any field, not to offer treatments that we really believe will not be beneficial. So to ask themselves seriously, do we believe that this is beneficial? And benefit should be defined by what the patient's goals are. And many times patients don't have just the interest in life. They have the interest in living under certain circumstances or living to achieve certain goals or living to be able to do certain things. And when you put it in that context, you realize that many of these things that we're offering clearly don't have benefit because what we're doing is prolonging life at all costs. But that's not necessarily what the patient is telling you when they want to live. Most of the time, there is a limit to what kind of life people want to live. Secondly, I think that oncologists, and again, this applies to any of us, it's not only our responsibility to be honest with patients, it's our responsibility to be compassionately honest with patients. And so I think that if they figure out a way to do that, to convey the compassion, the honesty is a little bit easier. Because I do believe that what's hard is the emotion in the room. And when you can express some compassion and understanding for the patient, even though the honesty is painful, it's a little bit less burdensome on you as a provider. The third thing that I feel could help oncologists is the fact that this happens for us in palliative care on the outpatient side. When we are able to have a longitudinal relationship with people, things like advanced care planning don't happen in one session. And the discussion about what care will look like as people move forward, even in oncology, shouldn't happen only in one session. They should be talking about the possibility that treatments may not work from day one. They should be talking about the possibility that at some point I may need to have a discussion with you that your cancer has gone beyond the point that we can treat with medical technology, so that when the time comes, you have kind of planted that or fired that warning shot so many times before that at least you've taken that sense of a shock out of the moment. One of the things that I love is this curriculum called OncoTalk, which was developed originally to help oncology fellows learn how to convey difficult information, not just from the perspective of the difficulty of understanding information, but emotionally difficult information. And it's been shown to really help oncologists be more comfortable with their communication with patients. And I think what we need to do is perhaps encourage some of our career oncologists that have completed their training that this might be a tool that's useful for them, not only because it helps in terms of avoiding this, what's called now, I guess, a bad outcome, right, which is chemotherapy near the end of life, but more often I think it will help them in terms of the stress that they experience with these conversations.
One of the most interesting things about this paper, really what you've been talking about, is that the oncologists know that they shouldn't be giving chemotherapy. They even know how to have the conversation, but sometimes it's just too difficult for them to do it. And if we can perhaps take some steps to help them be able to deal with that and give them support, I think maybe that really would make an impact. Are there any take-home points that you want to make before we end today?
My take-home point from the research, my initial reaction to our findings was really, gosh, we really need to support our oncologists better. And I'm not just saying this because they're the main source of my referrals, but I'm saying this because I really feel that they're in a situation where it's a no-win situation. If they do take the time to have these conversations, if they do allow themselves emotional vulnerability time after time in 15-minute blocks, they're going to burn out. And so I think the next step is for us to think about what is it that we need to provide our oncologists so that they have the emotional reserve to be able to do this. And what was funny is that I went around our cancer center and started asking people, like, what if we forced you to take an hour break every day to do yoga or walk on campus or sit in on a group therapy? And none of the oncologists were remotely interested in it. I'm too busy. I really do need the time. And I agree. We're all too busy. But I think maybe this is the first sign that oncologists need to really prioritize self-care as a way of providing better care for their patients.
All right. Well, thank you so much, Dr. Silveira, for speaking with me today on this fascinating topic that really impacts all of us and clearly needs more work to address.
Thank you.
And I want to thank all of our listeners out there who joined us for this podcast. The full text of the paper is available at jop.ascopubs.org. Don't forget, you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journal's mobile app, available at the iTunes Store and Google Play. This is Dr. Nate Pennell for the Journal of Oncology Practice signing off.